to the lecture on gastrointestinal disorders. Following today's lecture, you should be able to describe differences between the pediatric patients and adults in the design and function of their GI systems. You should be able to discuss the similarities and differences in structural, motility, inflammatory, and absorption disorders in the GI system. And you should be able to understand the fluid requirements of children. The GI system functions the same across the lifespan. This system is responsible for nutritional intake, breaking down food, absorbing nutrients, and excreting waste products from the food. When we look at the pediatric digestive system, we notice that the stomach is much smaller. Newborns only take a small amount of formula or breast milk at a time, sometimes even under an ounce when they're born. Intestinal motility is also greater in young children. Think of your newborns and your infants. They eat and excrete or have a bowel movement every 1 to 2 hours. Children also lack gastric enzymes to help digest solid foods at birth. And this is why we progress their diet slowly from liquids to solids to a regular diet. If we progress their diet too fast, the child struggles with diet changes because they simply can't break down the food. Also, the liver of children is very immature, and we have to make special considerations in the administration of medications. If we have a disorder that could affect the liver adversely, close monitoring of liver function is going to be important. By age 2, digestive maturity is complete. This age is important because it gives us a cutoff time for concern. So if a child is struggling with something gastrointestinal after age 2, it's likely tied to a physiologic process rather than just the maturity of their system. Cleft lip and cleft palate are defects in which the bones of the palate and/or the skin of the lip or nose do not fuse during fetal formation. The causes are mostly unknown, but we do know that seizure medication, diabetic medication, and environmental toxins are all risk factors. It's estimated that about 2,700 babies are born each year with a cleft palate, and 4,400 are born with a cleft lip. This is actually one of the most common birth defects in the United States. It is thought that taking folic acid during pregnancy could help with prevention. Cleft lip and palate are differentiated by location. Cleft lip may involve the nose and one side of the lip. It is usually readily apparent at birth. Early closure of the defect would help with latching and using bottle nipples. Cleft palate is less apparent and may be confirmed by manual palpation. Ultrasound or MRI can help determine the extent of the deformity and help anticipate and plan for surgical correction. After babies are born, you might see the doctor or the nurse stick their finger in the infant's mouth. We can check two things when we do this. We can check their sucking reflex, but we can also check for any cleft palates that might be present. Diagnosis can be made at birth on physical examination or during a prenatal ultrasound. A cleft palate or a cleft lip can elicit a very emotional response from the parent, depending on the severity of the defect. Nurses must be prepared to help families accept the child, understand the treatment plan, and the responsibility that goes with the care of their child. Treatment includes surgical repair of the cleft. Surgical repair is not recommended until 3 months of age, making multidisciplinary support even more essential. Palate repair may occur once the child is about 12 months of age. We wait until they're about a year old to allow for the developmental changes expected in that oral cavity. Dentures can be used in the interim to protect the palate and allow for feeding. These defects can have effects on speech, hearing, and dentition. Treatment teams often include speech therapists, dentists, oral and plastic surgeons, and the ear, nose, and throat doctor. Social workers and psychology may also be involved to help parents cope with their emotional responses. Postoperative care should include cleaning the incision, avoiding stress on the suture line, using the elbow restraints, and promoting bonding. I want you to think about why each of these are important. And I also want you to think about what would cause stress on the suture line. Would crying cause stress on the suture line? And I also want you to think about when you would use the elbow restraints and the device. When would you use those things? Could you take them off while the infant is sleeping? The answer to that's no, because even during sleep, they can pull and tug at that suture line. Eating is one of the biggest difficulties for these children. The defect makes it difficult for the infant to latch, suck, and swallow. We know that nutrition is essential to growth and development, so it's imperative that nursing care focus on meeting the nutritional needs of the child and the emotional needs of the family. Nursing support includes helping with feedings and educating the families on the importance of using adaptive equipment, as well as frequently burping the child. This slide shows some examples of devices that are available to help a child with this defect. You can see that the nipple has an adaptive device that allows for latching to occur deeper in the throat. The other device is a baby denture. It's used until the palate is closed and provides a means of rigid support that is needed for proper bottle feeding. What do you notice? And how might this impact care? What about parent education? The most important thing that you can do for the parents is to support bonding. Infants need their moms and their moms need them. They depend on mom for feeding and other needs. When moms can't do these things, as you know, it can affect the maternal-child bond. Therefore, an important piece to the care is the promotion of bonding. Nurses can help the mother feed the child in a proper way by using one of those devices shown in the previous slide. Nurses can also encourage parents to talk about their fears, their concerns, and their hesitations. Parents may fear what others think of their child, and nurses can help with that acceptance and help that family settle into their normal as they wait for the cosmetic repair. These pictures show some before and after photos of repairs. The difference is remarkable. Tracheoesophageal fistulas. We'll refer to this as TEF. TEF usually occurs as a result of the GI tract failing to separate properly from the respiratory tract in early gestation. It's commonly associated with polyhydramnios, which is excess amniotic fluid. TEF is a disorder in which the esophagus ends in a pouch, and then sometimes they reattach at a different point in the body, usually above the bifurcation of the trachea. These segments are usually connected by a solid cord. This is the most common form and is present in about 95% of these cases. Breathing and eating are difficult, if not impossible, for these children. This defect must be corrected. There can be many variations of this disorder. A child can have a double fistula, which is two fistulas attaching to the trachea. They could have a fistula without the esophageal pouch, which is called an atresia, or they can have an atresia without a fistula, and unfortunately that is a lethal condition called aplasia of the trachea, where the trachea tract is not present. When a child is born with this disorder, it usually is recognized during the first feeding or shortly following birth. The child will present with vomiting or choking, drooling, cyanosis, apnea, and abdominal distension. The symptoms vary depending on the extent and the type of the defect. For example, if the child has only an esophageal fistula, they may just present with vomiting. However, if the trachea or respiratory tract is involved, respiratory symptoms may also be present. Surgery is a must for this child. The fistula or atresia must be corrected so that the child can eat and breathe. The nurse will also be concerned with airway patencies, so the child may be suctioned to help with their secretions. The child will be NPO and possibly be fed using other means when appropriate and progress to oral intake as they heal or as the plan is made. These children could have a G-tube or TPN if appropriate. Pyloric stenosis occurs when there is a stricture or obstruction of the lower end of the stomach. This is not life-threatening, but it must be corrected to allow for absorption and processing of food. As a result of the stenosis, the muscles around the pylorus will hypertrophy, just to try to compensate for the narrowing, and gastric emptying is affected. You can see the muscles are enlarged around the pyloric sphincter and obstruct the emptying in the picture on the slide. The cardinal sign of pyloric stenosis is projectile vomiting. Not just a little bit of spit up, these babies forcefully projectile vomit. Parents may also report that the child always seems hungry. They may develop signs of malnourishment or also dehydration. Palpation on exam may reveal an olive-sized mass and abdominal tenderness. Fortunately, this disorder is easily treatable. A surgical repair of the narrowed areas is accomplished by creating a small incision in the right upper quadrant of the abdomen, and then they make an incision through the muscle to relieve the pressure. Another option that they sometimes use is a balloon and stent to open the narrowing. Depending on the surgical procedure, there could be incision care. Your treatment is going to be aimed with the goal of preventing dehydration. Therefore, small feedings will be given during the postoperative phase. These can progress as the child's body heals and they show that they are tolerating the feedings. The child must be kept with their head elevated to promote gastric emptying and to prevent aspiration. This may be accomplished using a car seat or a wedge. They will also have focused GI assessments and daily weight to monitor GI status. Here is an illustration of the before and after of a pyloric stenosis repair. Gastroesophageal reflux is common in kids, and it's noted a lot in premature babies, and it can also be associated with neurological disorders. However, any child can develop reflux as just a result of a lazy cardiac sphincter. The relaxation of the sphincter causes the gastric acid to reflux into the mouth and the GI tract. Unfortunately, children cannot tell us when they have heartburn, so many times they present by spitting up frequently, and then they can show a trend of recurrent ear infections also. If not recognized and treated, babies can develop aspiration pneumonia and apnea episodes due to the reflux. Management is important because weight loss can occur if this disorder is not treated. First, of course, it must be diagnosed, and this is usually done through an upper GI series to look at the sphincters and to grade the severity of the reflux. The series will look for GI damage that can occur from the acid, and then medications to manage it include PPI and H2 antagonist. However, home management usually involves thickened feedings to decrease aspiration and smaller volume of feeding to avoid overfilling of the stomach. Once the medication begins to work and the child's sphincter strengthens, then the treatment plan may be modified. Intussusception occurs when one part of the intestine slips into another part. Usually it occurs at the ileocecal valve and involves the small intestine going into the large intestine. It is very painful for the child, and it's the most common cause of a bowel obstruction in this age group. Due to its location, it can manifest much like appendicitis. However, the child's symptoms will help aid in the diagnosis. Symptoms of intussusception involve pain, screaming, and bloody stools. There may also be a palpable sausage-like mass in the right lower quadrant. The stools may be described as currant jelly. The stools look like currant jelly because of the blood and mucus that's produced when the portions of the bowel slide over one another and that friction occurs. Diagnosis involves an X-ray of the bowels and a barium enema. In 75% of the cases, the enema will actually correct the intussusception. However, if that doesn't occur, then surgery is needed to correct the problem. Here is a visual of an intussusception where the small intestine is going inside the large intestine. Hirschsprung's disease is also known as congenital megacolon. The child will present with bowel obstruction due to the absence of parasympathetic ganglion cells. In other words, there is a portion of the colon that atrophies because it doesn't work and there are no nerve cells present to cause peristalsis. I want to make something very clear. This in and of itself, Hirschsprung's, is not a bowel obstruction. It's the absence of those nerve cells, but it can lead to a bowel obstruction. It's very important to understand that difference. The area in the colon above where the atrophy is inflamed and enlarged, and it won't allow the stool to pass normally. This is common in males and can be associated with Down syndrome. It's also known to be hereditary and can run in families. 80% of children will present with symptoms during their first 6 weeks of life. If a large segment of the colon is affected with this disease, then symptoms may be present as early as 24 hours old. Symptoms of Hirschsprung's disease include no BM in the first 48 hours of life, ribbon-like stools, and a palpable fecal mass. The child may also have a potbelly and signs of obstruction. Symptoms vary with the amount of the colon that is affected. A barium enema or barium study is used to help diagnose this disease. The barium will map out the large intestine and it will illuminate the structures and the movement of the contents of the bowel. Once it gets to the affected bowel, the picture, of course, is going to change. This may then prompt them to do a biopsy of the area and look for Hirschsprung's disease versus other causes of obstruction like a tumor. The cells are also examined for the absence of the nerve cells. It's important, though, to evacuate the bowel, so enemas may be used to facilitate this until surgical repair can be accomplished. Surgical repair involves a temporary colostomy. During this surgery, the affected bowel is removed and the healthy bowel is exposed through the colostomy opening to allow the body to heal and adjust to the repair. It may take a few weeks to get this regulated as the bowel recovers slowly when we surgically mess with it. The patient will need to be educated on colostomy care and reminded that this is a temporary thing. The child will then return to the hospital and have this colostomy reversed at a later date. Given this surgery, the child is still at risk for obstruction and inflammation post-operatively due to the scarring, but this issue should resolve by the first year of life. The long-term outlook is very promising for these children, and surgical intervention is usually not needed after the initial repair. Hernias are defined as a protrusion of an organ or part of an organ through the muscle wall of the cavity it contains. Most often, it's identified in newborns, and it's due to the failure of normal openings to close during fetal development. In other cases, in older children, it can be due to weakness in the supporting muscles. Hernias are usually visible when the pressure in the area of the hernia increases. When a child cries or strains to maybe have a bowel movement, the hernia may be visible as a protrusion in the groin or around the belly button. There are 3 types of hernias that we'll discuss: umbilical, diaphragmatic, and inguinal. Umbilical and inguinal are usually common and nothing to get excited about. However, diaphragmatic hernias, they are when the abdominal organs protrude into the thoracic cavity. They can be very serious and life-threatening. because that pressure and position can lead to respiratory issues. Also, the risk of incarceration is high with diaphragmatic hernias. Umbilical hernias are a type of hernia that occurs most in children. As you can see, the bowel protrudes through the umbilical opening where the umbilical cord was once attached. It is common in preemies or children with low birth weight, but it can certainly happen in any child. It is usually soft and you can easily push it back into the opening. These either spontaneously resolve by about age 1 or they may need surgical intervention. Surgical intervention is required if this defect enlarges, if it strangulates or incarcerates, or if it doesn't resolve by the time the child is 5 years old. Inguinal hernias are defined as painless inguinal or scrotal swelling that occurs when the abdominal tissue extends into the inguinal canal. Parents usually report a bulge in the groin or note the swelling in the scrotum when the child cries or strains. It's treated with surgical repair because this is a hernia that does not resolve on its own. Parents should be educated on the symptoms of strangulated hernias so they can monitor the status if the surgery to repair the issue is delayed. So nausea, vomiting, abdominal pain, bloody stools, blue color to the hernia, irritability, all of those can be signs of a strangulated or incarcerated hernia. This is important to educate the parents about because a strangulated or incarcerated hernia is a medical emergency that requires immediate surgery to prevent necrosis of that tissue. Non-emergent surgery is done shortly after finding the hernia, especially after 3 months of age. Nursing care for hernias involves wound care, infection control, and pain management. If a diaphragmatic hernia is repaired, an ICU stay is going to be part of the care plan. Appendicitis is an emergent condition that occurs in adolescents and young adults. It can occur at any age, but this is the group with the highest incidence. Typically, these teens come to the emergency room complaining of right lower quadrant pain, especially upon palpation or pressure. This can be called rebound tenderness. The pain has a distinct pattern which involves periumbilical pain that then localizes to the right lower quadrant. The abdomen may be rigid and the patient may guard the abdomen. They may also have nausea, vomiting, diarrhea, and chills. This pain does not let up and it tends to worsen throughout the day. The biggest risk of this condition is rupture of the appendix when it becomes inflamed, infected, and swollen. 25 to 30% of pediatric cases are misdiagnosed, so it's important to monitor for perforation by conducting a thorough abdominal exam, including palpation by the doctor, and also examine laboratory and diagnostic data to determine the appropriate interventions. You may hear the term McBurney's point. This is the area where the pain is most severe after palpation. When compressed and released, the patient experiences a sharp surge of pain. If appendicitis is suspected, it's going to be confirmed by an ultrasound or a CT scan, and then the determination for surgery is going to be made for now or later based on the symptoms and the test results. The treatment regimen includes NPO, surgery, and antibiotics. If a rupture has occurred, the hospital stay for the child is going to be longer, but traditionally the patient stays about 24 hours and then is sent home using ibuprofen or something similar for pain management. Wound care is going to be needed for the small puncture wounds or incisions used during laparoscopic surgery. The biggest risk of this condition is rupture as the appendix becomes inflamed, infected, and swollen. Initial workup in the ED should include a CBC, and if the white count is greater than 15,000, then you should suspect that a perforation has occurred. In addition, a full rupture could occur if the child's symptoms suddenly resolve. If rupture occurs, peritonitis occurs as fecal matter and bacteria mix within the peritoneum. This is an emergent condition as the patient can develop septic shock. In addition to surgical debridement of the rupture, patients will also have an NG tube to rest the bowel, a JP drain to drain any abscess or infection, and several days of IV antibiotics per central line to treat this very serious condition. Recovery can often be painful, therefore opioid use is appropriate in this patient. A morphine PCA may be the mode of choice should the patient be mature enough to use it properly. Gastroenteritis is an inflammation of the stomach and intestines that is often accompanied by diarrhea and vomiting. Many times it's caused by a virus, but it can be caused by a bacteria or a parasite. However, in some cases, it can be a chronic problem associated with illnesses like colitis, short bowel syndrome, or food intolerances. Rotavirus is a leading cause of gastroenteritis, but the incidence of this cause has decreased since we started vaccinating for rotavirus. Even though there is a vaccine, it still does continue to be a major problem throughout the rest of the world. It's extremely contagious and often causes fever, vomiting, and watery diarrhea. Children will have multiple stools per day. Nursing responsibilities are going to include rehydration, contact isolation, and helping stop the vomiting and diarrhea, and helping control the fever. The biggest complication of gastroenteritis and rotavirus are dehydration and electrolyte imbalances. Therefore, treatment is going to involve infection control to prevent transmission, fluid and electrolyte replacement, and management of diarrhea, and the replacement of lost bacteria. Patients may be asked to follow a BRAT diet, and clear liquids should be encouraged, such as Pedialyte. Labs are going to be monitored as well to assure that the patient has not developed a sodium or potassium deficiency. 1.5 million cases of dehydration are managed in outpatient settings each year. Over 220,000 patients are admitted for dehydration every year. Dehydration can occur for many different reasons, but it's very important to understand why children develop it frequently and why it's essential to correct it properly and efficiently. At birth, 90% of a child's weight is made of water. This is decreased by about 60% by age 1, and it remains at this level through adulthood. In addition to this, children have a higher body surface area, and that predisposes them to increased water loss. The other complication of dehydration is compensation. Children's kidneys are not mature until they're about 2 years old. Therefore, their kidneys cannot conserve water and electrolytes properly. So children depend on oral rehydration as well as IV resuscitation when we suspect dehydration. 3 types of dehydration occur in children. You have isotonic dehydration, hypotonic dehydration, and hypertonic dehydration. The first 2 are commonly caused by diarrhea and vomiting. It's important to recognize the clinical signs of dehydration so that you can intervene appropriately. It also helps to determine if hospitalization is required or can the parents manage this at home. Dehydration can range from mild to severe. Mild dehydration occurs when the child has lost up to 5% of their body weight, and some symptoms include just being restless and thirsty. Otherwise, they seem normal and their perfusion is normal. However, as the dehydration progresses, the child loses more weight and shows more signs of a dry system and a poorly perfusing system. This is where symptoms like rapid pulse, delayed cap refill, sunken eyes, dry mucous membranes, the inability to make tears, and all of that start to happen. Those symptoms require immediate intervention, and it's considered a pediatric emergency. Hypovolemic shock is a state of imbalance in the body that is caused by a defect in fluid volume. Typically, hypovolemia is either hemorrhagic, which is caused by blood loss, or non-hemorrhagic, caused by fluid loss. Generally, if we treat the cause of the shock, then the shock is going to begin to resolve. For example, if hypovolemia is caused by diarrhea, we would correct for the fluid shift with fluid replacement and provide antidiarrheals to correct the causative agent. Symptoms of hypovolemic shock in children can vary depending on the severity of the shock and the degree of compensation of the child. Common symptoms are lethargy, dry mucous membranes, absent tears, tachycardia, hypotension, dark urine, a decrease in wet diapers, sunken eyes or fontanelles, hyponatremia, an increased BUN, and a decreased sodium bicarbonate. Capillary refill can be compromised if compensatory mechanisms begin to fail. Correction for hypovolemia involves oral and intravenous fluid resuscitation. Common oral rehydration solutions include Pedialyte or a solution composed of water and electrolytes, including sodium. Ingestion of these solutions are weight-based and may be ordered following each stool or each episode of vomiting. In order to comply, it may be necessary for one to add Zofran or an antidiarrheal medication so that the fluid stays in the system. The amount of fluid may be increased as the child progresses and improves. Eventually, a traditional diet can be resumed. Intravenous fluid resuscitation may begin with a fluid bolus. This is a specific amount of fluid given rapidly over 5 to 20 minutes. The amount and rate are based on the weight of the child. The types of fluid will be based on the electrolyte imbalance and the type of fluid lost. Most often, an isotonic crystalloid is given as it will restore water and sodium loss. If the hypovolemia is caused by a burn or by diarrhea, lactated ringers is usually used. D5W can also be used, but must be cautiously monitored. It may help in situations where there is a known metabolic need. Lactose intolerance and celiac disease are disorders that involve inability to digest various food ingredients or foods. With lactose intolerance, a medication like Lactaid may be able to be taken prior to meals to allow the person to ingest lactose and enjoy some dairy products. Celiac disease is the inability to digest gluten. If gluten is ingested, the patient usually develops diarrhea and abdominal pain. They can also have things like iron deficiency and growth impairments because the body is not getting its nutritional needs met. Here are some symptoms that you can see with celiac disease: chronic diarrhea, abdominal pain, iron deficiency, growth impairment, a poor appetite. Gluten is found in wheat, in barley, in rye, and in oats. That is why many pediatricians recommend rice cereal rather than oatmeal for an infant's first infant cereal. The treatment for celiac is usually diet modification and elimination of gluten. Any age group can develop these disorders. What challenges do you see among each age group with dealing with this diet modification? Also, what about cost? What kind of barriers and challenges could this present for a family? The final GI disorder we're going to discuss is encopresis. Encopresis is a phenomenon that occurs in children when they ignore the urge to defecate. Children can ignore the urge for various reasons, but research shows that the most common reason is stress or abuse. Failure to defecate results in constipation, pain, fissure development, rectal enlargement, and stool leakage. Treatment involves correcting the cause and then reestablishing the toileting routine. Nursing care must be approached very sensitively in this situation. Welcome to the lecture on GU disorders. The genitourinary system is composed of the kidneys, ureters, bladder, and urethra. Its job is to regulate fluid and electrolyte balance in the body and excrete waste products. Normal renal function requires unimpaired renal blood flow, adequate glomerular filtration, normal tubular function, and unobstructed flow. In other words, the kidneys must be perfused, the system must be able to filter waste and carry urine and get it outside of the body. Pediatric differences to highlight in the GU system are kidney maturity. Before age 2, the kidneys lack maturity to regulate fluid and filter waste. Therefore, a young child has difficulty compensating when a volume deficit occurs, and kidney injury can occur very quickly. Usually, when hypovolemia occurs, the body will immediately shunt blood to the kidneys. It will restrict output to conserve water and electrolytes necessary for sustaining the body while in crisis. The child is unable to do this fully until they're at least 2 years of age, and that's when kidney function improves dramatically. Also, their bladder capacity. Baby bladders are very small. However, as a child grows, so does their bladder. In addition, bladder control is not developed prior to age 2. This is because the nerve development has not occurred yet to allow this to function prior to that age. These differences can contribute to the common problems seen in our pediatric patients. This is a chart that just shows milestones in the development of bladder control with children. Urinary tract infections are the second most common infection in children. There are 2 types of UTIs. You have cystitis, which is the bladder, and pyelonephritis, which is the ureters, pelvis, and parenchyma. They can be caused by bacteria, virus, or fungi. They affect girls more than boys, and it is thought that by age 7, around about 8% of girls will have had a UTI. This problem can also be a chronic one, where the child will have multiple UTIs. UTIs in children occur for the following reasons: urinary stasis, limitations in hygiene, and improper cleansing after a bowel movement. Urinary stasis can occur due to anatomical structure abnormalities or conditions such as a neurogenic bladder. Infrequent voiding can also cause urinary stasis and inadequate bladder emptying. Hygiene issues can result from irritated perineums or sometimes uncircumcision. Constipation and sexual activity can also increase the incidence of UTIs. Therefore, UTI's highest incidence occurs in the first year of life, then may peak again in adolescents or school-aged children. Reflux can also cause UTIs. Symptoms of a UTI can be difficult to detect in young children. However, fever, strong urine odor, poor feeding, and irritability can be reported by parents. Diagnosis usually involves urine specimen collection and analysis. A quick dipstick can be done in the office to check for white blood cells or nitrites. Urine specimen collection can occur with child voiding in a cup or a urine collection bag. You can also use a straight cath to obtain a specimen. Following treatment, parents should be educated on the prevention of recurrent UTIs. By age 6, a child's renal system has developed and they should have the ability to control their voids. However, in some cases, this milestone isn't achieved and we must understand why it occurs. Enuresis is incontinence in a child old enough to control their bladder. There are 2 types: primary, which is where the child has never had a dry night, usually attributed to maturation delay or a small bladder, and secondary. This is where the child was reliably dry for 6 months, then begins wetting, and this is usually caused by stress, infections, or sleep disorders. If the problem occurs during the day, it's referred to as diurnal. If it occurs during the night, it is nocturnal. Children can have both diurnal and nocturnal enuresis. Because there are a variety of factors, constipation, structural defects, infection, diabetes, parents should be encouraged to treat the cause before managing enuresis. For example, my son struggled with this. However, this was partially due to constipation. We were encouraged to treat with a Miralax regimen for the constipation, and this resolved and became routine as my son aged. The episodes of nocturnal incontinence decreased and then stopped. However, in some cases, parents may need to initiate a treatment plan to include bladder training, recognition of the urge to void, and maybe medication. One of the most common ways to treat is to limit fluids after supper. This way, the fluids have time to excrete before bedtime. Another option is to set an alarm during the middle of the night or place an enuresis alarm in the bed to wake the child before or as they are experiencing the bedwetting. In other words, the alarm goes off when it detects wetness. This may encourage the child to get up and go, or it may help them recognize the urge and go before it happens. There are many ways to help a child, but parents must be encouraged not to scold or punish the child for this problem because it can't be helped. I also want you to understand that this is like a stepped treatment therapy where we would start with the most or the least restrictive modification first. Usually we start by trying to do simple things like behavior modification, maybe offering rewards for dry nights, and then limiting fluids, and so forth and so on. Nephrotic syndrome is not a disease, rather it is a clinical state or a process of symptoms that causes alteration in kidney function secondary to increased permeability of plasma proteins that results in excessive proteinuria. Nephrotic syndrome can have many causes. It can be due to congenital defects, or it can be caused by drugs, toxins, or some kind of systemic disease. 85% of children with nephrotic syndrome have a primary disease called minimal change nephrotic syndrome, or MCNS. Regardless of the trigger, the disease process begins with increased permeability to proteins. The kidneys get lazy and they let the large molecules through to be excreted into the urine. Proteinuria causes the pressure in the body fluid to shift, and it traps fluid in the interstitial space, and that's what causes the edema. In addition, the extreme loss of protein in the body has systemic effects on the child's immunity, because when those proteins are excreted, immunoglobulins are lost. Hypercoagulation and hyperlipidemia happen because albumin triggers a response from the liver to coagulate and increase fat synthesis, and the kidneys retain water and salt. If not treated, a child can develop end-stage renal disease because their body just can't compensate for this loss. Manifestations of the syndrome include weight gain, edema, ascites, proteinuria, hematuria, hypertension, renal hypertension, low urine output, and the loss of appetite. So you can see things are just not adding up. They might also have periorbital edema present upon waking, but that usually resolves as the day progresses. Kids may also report that their clothes don't fit due to the swelling, edema, or ascites. The urine characteristics may include frothy or foamy urine. Diagnosis is usually made on the symptoms and the lab findings. Children may have an albumin level below 2.5 and protein in the urine over 3.5 in a 24-hour reading. Treatment can occur inpatient or outpatient depending on the severity of symptoms. Corticosteroids are the first-line drugs in many cases because they're going to decrease protein in the urine. In other words, treating the culprit of a lot of the problems. The regimen of corticosteroids lasts for about 10 to 12 weeks, so the child is given a high dose of steroids and then completes a slow taper over the last 4 to 8 weeks. 95% of cases do respond to this treatment. In severe cases, drugs like furosemide and albumin replacement may be needed. Other treatment necessities are diet modifications, including fluid and sodium restriction and a high-protein diet. Since steroids are the primary line of treatment and are given over long periods of time, nursing care must include assessing for secondary infections that might be masked due to the prescription, assessing vital signs, watching for thrush, diarrhea, and urinary changes are going to be essential. We also want to monitor intake and output and daily weights to assess the response to treatment. If the child has ascites, then we're going to want to measure that abdominal girth. Electrolyte imbalances should also be monitored because hyponatremia and hypokalemia may occur in various stages during recovery. Skin care is going to be important as that skin relaxes and the edema resolves. Body image disturbance is a real thing here as school age and adolescents can be affected by this syndrome. Children can also develop a condition called acute post-infectious glomerulonephritis. This acute process usually develops 10 to 21 days following a bacterial infection. The most common bacterial infection that leads to APIGN is strep throat. The infection triggers an immune reaction that causes the glomeruli in the kidneys to become inflamed and obstructed. Therefore, the body tries to compensate by increasing vascular permeability. However, when they do that, that allows the red blood cells to be excreted. The kidneys naturally compensate by retaining sodium and water, so you're going to see edema present in this condition also. This slide looks at the injury phase, which occurs after the infection, when the immune response begins to cause the initial obstruction and inflammation. The proliferative phase begins when the body tries to compensate for this injury, and there's decreased glomerular filtration, vascular permeability changes results in red blood cell excretion, proteinuria, and edema. During this phase, children may or may not show symptoms. Then the body will go into a reparative phase in which the response to treatment is occurring. Cellular debrief can be removed and new membranes develop to restore kidney function. It is possible that kidney function is decreased after the APIGN, and children should be monitored for kidney damage. A classic symptom of this disease is tea-colored urine due to those red blood cells that have been excreted. However, children may also present with symptoms of nephrotic syndrome secondary to this infectious process. Laboratory tests may include a urine dipstick to check for the presence of red blood cells and protein. A urine-specific gravity may be monitored to determine how well the body is filtering waste. BUN and creatinine are going to be analyzed to determine if damage is occurring to the kidneys. And an ASLO titer may be ordered to determine if an exposure to group A strep has occurred. Treatment is going to include antibiotics for the group A strep. We're also going to treat supportively and give medications where needed depending on the symptoms that the patient is having. Bed rest is going to be essential because the body needs time to repair from the stress of this process. Nursing interventions are going to be aimed at monitoring fluid status, but recovery is long, so monitoring can last up to a year.